All right, folks, well, I guess we are Twitter Live here. I haven't done previously Twitter Live, so please excuse any issues or any problems we may be facing, or don't, really. Chadi Nabhan here, the host of the HemOnc Pulse, and I am here at the 11th Annual SOHO Meeting in muggy and hot and warm Houston, Texas. Couldn't be happier to have Drs. Loghavi and Khoury with me, two phenomenal pathologists, to talk about a few things pertaining to MDS, AML, MRD, all of the above in the next 15 to 20 minutes. Joe, do you want to introduce yourself to folks who are watching us?
Absolutely, Chadi. It's a pleasure to be here. My name is Joe Khoury. I'm a hematopathologist by training and by subspecialty expertise. I'm the chair of pathology and microbiology at the University of Nebraska Medical Center in Omaha, Nebraska, where it's much cooler than it is here today in Houston.
Any place is cooler nowadays.
But both places are lovely, and I'm glad to be here today.
And Dr. Loghavi?
I'm Sanam Loghavi. I'm a hematopathologist and a molecular pathologist at MD Anderson here in Houston, Texas. So this is home for me, and delighted to be here live on X today.
Yeah, we haven't done this before, so we have no idea how it's going to go, by the way, so there's no edits. And you know, you're a prolific tweeter. And one of the things that you have done nicely is on the educational platform, really talking a lot, some of the classifications that have done recently, and at the risk of sounding very redundant, talking about the classifications between WHO, ICC, or myeloid malignancies, I'm still going to go there just a little bit, because I want to try to simplify a complex topic for folks who get your report and they're trying to understand what to do. Are you adopting one classification versus another? Are you reporting both? How do you simplify this to the non-hematopathologist?
Sure. So this is a touchy subject, but I thought you would touch on the touchy subject.
Of course, live Twitter,
Right,
I have
like,
to.
No. So, you know, I think in essence, everyone knows there's new classifications, and I think the gist of both classifications is that there's more emphasis on genomics and less emphasis on morphology, sadly, for the hematopathologist in me. But of course, I think, you know, we're
just wait until
excited.
AI takes over, then we'll talk.
Oh, no. We're just going to use AI to improve. But, you know, I think it's, of course, I think the field has moved towards genomic classification. And I think this is better. Obviously, it has refined our classifications. Both AML and MDS are now genetically defined for the most part. So if we can genetically define and classify anything, we use genetic classification, and we revert to morphologic classification or phenotypic classification if we really have no genetic markers of differentiation.
Actually, I love that. This is really a very nice way of looking at classification, molecular, and then the other. It was the opposite.
Yeah, it's now based on genetics.
Joe, what triggers you guys to decide that there's a new classification that I need to? Is it you have to do it every 5 years, 10 years? Is it based on knowledge? What made you decide that there's a time for a new classification?
That's a great question, Chadi. So certainly, when we practice medicine in all of our specialties, it is important to stay up to date with the science and to incorporate the science and the advances in knowledge into our daily practice. And when it comes to cancer as a whole, we do this through an established standard classification, that is the WHO classification. And this is true across all subtypes of cancers or all organ systems that we basically have a cancer classification for, which has been in place for many years. The WHO has adopted a 5-year cycle for this latest edition, which is the 5th edition of the WHO classification. It started in 2017 and is slated to end in 2013. Now, not all the blue books will be released in the public domain in print at the end of 2023, but the content of the 5th edition is pretty much complete. Now, what that means is that we're through over 2,000 experts that have contributed to the 5th edition, we were able to amass advances in science, advances in medicine, and make them part of the classification of cancer today. This is true, of course, for the hematolymphoid classification, And we continue to think of the WHO classification really as the global standard in that domain. There's always room for input, there's always room for advice and looking and reflecting to make sure that the classification is addressing all the key questions it needs to address. And in that spirit, of course, colleagues who contributed to the ICC have had their voices heard, and actually ICC terminology has been adopted wherever possible into the WHO classification. But I think it's very important for us to talk about one classification, one standard that governs our approach to classifying cancers.
How uniform is how consistent our hematopathologists are in signing out some of these things? There's always been, the classic example I used to tell colleagues is follicular lymphoma, whether it's grade 3A or 3B
right.
sometimes. How, in your experience, are you looking at the consistency and the homogeneity in how you approach things? Because I think the more we sub-classify things, the more it becomes difficult on everybody.
Right.
But let's face it, not everybody is practicing at the top institutions in the country.
Yeah, I think, so the way I look at it, I think hematopathology has become more and more complicated and complex as we've, developed newer techniques and have become better at, again, genetically classifying disease, right? So I think what happens is, for the most part now, HePath is being signed out, or hematopathology specimens are being reviewed and signed out mostly by hematopathologists. It could be in the community, but they're usually people that are HePath trained, or they're being referred for hematopathology, consultation. The one thing that I would say is I definitely would advocate for consistency. I think it's important to, adopt up-to-date terminology and be consistent, because the ultimate goal of our reports is to help our patient-facing clinical colleagues to deliver the best care that they can to their patient, right? So if my report is ambiguous and the clinician really can't understand what they're dealing with, that doesn't help anyone, right? That may just protect me as a pathologist, I'm trying to be ambiguous, that's not helpful. And, I think what we want to do, and hopefully our goal, is to help the patient get the best possible care that they can.
Since these new classifications, have you been getting a lot of second opinions from other pathologists to review like slides for AML or MDS or lymphoma even?
So, the practice at our institution is that any patient that walks through the door for treatment at MD Anderson will get their pathology reviewed by our pathologists. So that's one way. I think we get a lot of informal consults through email, Twitter, questions, about the classifications and how you apply them to cases from our, community colleagues, which we're happy to help with. But the bulk of our consultation practice, if you will, is actually patients that are coming to be treated at MD.
Joe, with there's a lot of buzz in hematologic malignancies about MRD in general. You pick your disease and people talk about MRD. How involved is the pathologist, the role of the pathologist, in deciding the quote-unquote MRD assay that you're going to use, the definition of it, and even the interpretation? Because I presume obviously the clinician is going to decide what to do with the results, but to get there, how involved are you guys in it?
Well, I would think of pathologists as the experts in test selection in the clinical domain. Certainly when it comes to subspecialty areas that are complex, as Dr. Loghavi mentioned, as hematolymphoid classification of diseases is today, choosing the right tests at the right point in time becomes really complex and a subspecialized area of subject matter expertise. It boils down to having excellent communication between the pathology and lab team and the clinical provider team that is making decisions on treatment selection. And so, back to your question, if you think about the tests that we have at our disposal, each test has pros and has cons, has its strengths and has its drawbacks. If we look at a bone marrow under the microscope, we can get so much information through expert eyes, but we cannot get the depth of sensitivity that, as an example, a measurable residual disease assay or MRD assay that's designed to detect rare events in a population of 200,000 cells with the human eye. It's just not possible. And so the point here is that each test methodology has different layers of sensitivity. And we need to know when to apply each test, at what point in time, to make the maximum benefit out of it, so that we're asking, if this patient's disease looks cured when I look at it under the microscope, is it really gone, or am I just not able to see it? Well, the truth is that I'm just not able to see it beyond a certain point.
Right.
And so the beyond a certain point then invites us to use flow cytometry as an MRD tool, and to even go beyond, because flow has also a bottom capacity in terms of its sensitivity. We can go deeper through assays that are maybe molecularly based, that can be applied in certain disease contexts. Those of you
flow gets attractive just because I think it's more available.
Absolutely.
In a community setting, right?
Absolutely, but those of you, maybe you had a chance to listen to Dr. Hagop Kantarjian yesterday talk about this amazing success story with adult ALL over the years, adult and childhood ALL. And what Dr. Kantarjian said is that as the treatments got better, the need to be able to detect more and more rare events in a patient's body, asking, is there still ALL there or not, has been commensurate with the depth of responses. And so now we get to a point where, through sequencing, we can detect 1 in 10 to the minus 6 or 10 to the minus 9 cells. And that level of sensitivity now is giving us perhaps the ultimate in MRD measurement. It's not a flow assay, but that doesn't take away the value of flow in other places, but it certainly adds to it and becomes an added value.
Is there this dialogue between the pathologist and the hematologist deciding this? I see what you're saying between flow, and you can name the different ones, but how does it actually work? You pick up the phone and say, well, maybe we should not do flow here, we should do something else. How do you decide what to do?
I think it depends on, in an ideal scenario, at a place like MD Anderson, with all the resources that we have, when we have a good sample, we try to do everything. But there are instances where you have a limited bone marrow, right? The sample is limited in quantity, and you have to select, you have to be selective. Which test is going to be the most high yield? And that will essentially depend on the baseline characteristics. Let's say if I am dealing with an NPM1 mutated AML, perhaps sending the sample to the molecular lab and getting an NPM1 PCR is going to be more informative for MRD. But if I am, dealing with an AML that has MR or myelodysplasia related mutations that may not be as informative for MRD assessment, then flow is going to be the best test for me to look for MRD. And so I'm going to send that. And I think that really the pathologist decides that, at least at our institution. We're the ones that are triaging. The clinical team places all the relevant orders, but if the test needs to be triaged, we're the ones that are triaging.
That's a good point.
To add, Chadi, maybe to add to also what Sanam said, it is context specific, right?
Yeah.
We can set this strain to go, and it's going to work for 90% of patients very well. The key is identifying those nuances that require a slight modification here and there, so that we can deliver the best possible care.
So hey folks, we are on Twitter Live and we're trying this new thing, so make sure you just drop a comment or an idea if we're doing a good job. a bad job, don't drop any comment, please. It's okay.
And if you can specifically like me.
Yeah, if you can just make sure Dr. Loghavi here, for sure. But I cannot have two pathologists, phenomenal pathologists, on live Twitter without asking about AI. I can't.
Oh, please do. Please do, please.
So what I have noticed, and correct me if I'm wrong,
Yeah.
in my interactions with many of my pathology colleagues, a lot of the pathologists I have been talking to, they are embracing the AI approach, and to your earlier point when we were joking about how it helps this. So I guess I want to hear from both of you about the same topic. What is AI in pathology? How are you really approaching it? What is even AI for the non-pathologist on pathology? I don't know. Try to help us understand how are you bringing that technology in a way to help you as a pathologist and for the patients.
Yeah.
And both of you, the same question, because I'm hoping that you're not going to agree, and that will get me more clicks on Twitter.
There's a very high chance that we're going to agree quite a bit, because both of us have been thinking about this, working on this, and really trying to push the tip of that spear as forward as we can with the technology that we have. Now, when we talk about AI, artificial intelligence, or machine learning, AI/ML, I think it's important to keep a few concepts in mind. One is that when we apply algorithms that are running a software code in the background on, let's say, a digital image, we have to be very careful in understanding the output of that algorithm and making sure that it is answering questions that are clinically relevant and represent gaps that the human analytics might either not be able to do it or might struggle with it because we don't get exposure that gives us the expertise that a programmed algorithm can provide. That's one. Two, it has to be viewed as a diagnostic aid, not as a replacement for the human intellect that really is the best tool we have today to take the global picture in perspective and use AI as a service to provide the best possible diagnostics. There's definitely a big effort now that's led by the College of American Pathologists in our field to really define the scope of AI and machine learning in how it applies to pathology, identify the regulatory requirements that we need to meet so that we can implement AI safely and reproducibly within a clinical environment. And not the least is the third component, is how do we recoup the costs that are inevitably going to be part of AI and machine learning algorithms. I think we have to view them like the same way we view special stains and we view special tests in the lab, and we need to treat them with the same level of a combination of skepticism and clinical validation, and also view them from an economic standpoint as tools to improve our care. Sanam, maybe I took too long on this, but yeah.
Actually, I'll ask you, and I know we have a hard stop, but instead of, because I think we probably agree with most what Joe said, but my question to you is, where are we? Like, if you had to say, where are we currently in AI? It's being studied and looked at. How far are we from truly applying AI in clinical, where you really, potentially, I presume, it improves the accuracy of diagnosis in some ambiguous cases?
I mean, I would say AI is being used right now in certain scenarios. If you think about television is a form of AI, right? It does your CBC and differential for you, and it's artificial intelligence. Now, are we routinely using AI in our hematopathology diagnostics right now? that would be about 0%. But again, I would say maybe not, maybe about 5%. We do have machine, computer-assisted quantification of immunohistochemical states. So that's a form of AI. I think, where AI is going to be very helpful to us and in the near future is going to be in the mundane tasks that we have to do. And I welcome that. I want the computer to count cells for me so I can think about more interesting things, right? But I also think it's going to be very impactful in analyzing large data, things that we cannot do as human beings. But I think it still needs to be, just like any other technology, driven by human intellect. And sure, will there be a day where pathologists, I think our job description is going to change. And in fact, our job description has changed. Pathology, the way I practice hematopathology right now, is nothing like hematopathology was when I was a trainee. It's completely different. The way we make a diagnosis is completely different now. Some of it is based on technology, but I think it's a welcome change, and I look forward to using all the fancy tools.
So we're going to do another Twitter Live at ASH.
Okay.
It's happening in San Diego. Folks, thank you so much for being here on our first HemOnc Pulse Twitter Live with the amazing Drs. Khoury and Loghavi. And until ASH San Diego, tune back in to the HemOnc Pulse.
Thank you for tuning in.